All the panelists, we are now audible and visible to the audience. We are also live on YouTube. Dr. Mandirata, can you hear us?
Right.
Yeah, thank you.
Good afternoon, good evening, good afternoon, good morning. We are in different parts of the world, so it's important to have both morning and evening wishes for everyone. So today's meeting, welcome to the first meeting of the joint symposium of the Indian Academy of Neurology and the Indian Epilepsy Association. This has been the brainchild of our Indian Academy of Neurology President, Dr. Nirmal Surya. So it's only appropriate, and it's been very well supported by the Indian Epilepsy Society and the President, Professor Mandirata, and Secretary, Dr. Manjari Tripathi. So I would request both the presidents to initiate the proceedings of this symposium and this series of symposiums by saying a few words. First, Dr. Nirmal Surya, the President of the Indian Academy of Neurology, and then Professor Mandirata, the President of the Indian Epilepsy Society. I note that Alexis has not joined as yet. I've just sent him an email. He had just sent in an email that he's joining quickly, but till that time, I think if that is the case, then the order of the presentations, the order of the speakers might have to be reversed. And this is a housekeeping announcement for the chairpersons. So Dr. Surya, please, and then Professor Mandirata.
Thank you, Gagan. It's indeed a pleasure to welcome you all on today's webinar, which is a joint webinar with Indian Academy of Neurology and the Indian Epilepsy Society. I'm extremely happy that Indian Academy of Neurology in last couple of months has started joint symposium with subspecialties of the neurology. And to begin with, the first of them is with epilepsy. We are going to have in this month 2 more subspecialty joint seminar. One is with the Indian Stroke Association, and then another one with the Association of Child Neurology. So these are the upcoming joint symposium which are going to have between the various organization of subspecialty. The idea behind that is that we would wanted the best possible education for all the neurologists member of Indian Academy of Neurology. I know there were some criticism that, you know, epilepsy is, there is a society, why you want a joint symposium, or stroke is a society, or movement disorder is a society. But I feel that Indian Academy of Neurology being a large umbrella body which has got nearly 3,000 members today, all of them are not the member of the subspecialty. And it will be wonderful to have an interaction with this subspecialty in term. I'm helping this subspecialty because some of these members who will be attending this webinar may be attracted or interested in becoming the member of this subspecialty. So this is going to be a win-win situation for everyone. At the same time, the expert in the field, and I'm extremely happy that Gagan has brought the great speakers. Professor Trika is here already, and we will have Professor Alexis from France joining him along with our own Sita. So I'm sure today's webinar will be a landmark webinar, and Mandirata and Manjuri is here, and we look forward to have similar sessions maybe in the future, if not twice a year, then at least once in a year. And with that note, I also want to thank our subsection of epilepsy of IES chair, Dr. Sangeeta and Chaturbhuj Rathod, who was very actively involved in last 6 months. I have been pushing them to do various activity, and they have been positive and has been there everywhere. So thank you, both of you. And with that note, I thank all of you to having given me support to take the journey forward. Thank you.
Thank you, Dr. Nirmal Surya, President of Indian Academy of Neurology. And I wish to thank everyone who is present here, the conveners, Dr. Gagan, Dr. Manjari Tripathi, and Dr. Sangeeta Rawat, Dr. Chaturbhuj Rathod, and the speakers. As Gagan already mentioned, it's a good, always academic activities are welcome, and we welcome with open arms, and if it's to the benefit of medical fraternity. I wish to, Gagan has already extended the warm greetings twice. As the world over, he has extended already. So I like to say my friend is already there who is internationally renowned Alexei and Ojin Trinka in the neurology fraternity and epilepsy fraternity. I think they will be introduced subsequently, and we are going to be enriched by the academic talks by both of them. They are so well known, they are doyens in the world. And I would like to say to Ojin Trinka, I think still he speaks some German, is Guten Morgen, Ojin. He had always been helpful. He helped us to review the phosphoenatoin guidelines of Indian Epilepsy Society. And he always say, wherever he sees us sitting, oh, my friend, come on, how are you? So he is such a warm person and really impressed with his academic abilities, publications, degree of talks, and communication. So with these, I will like to extend once again warm welcome to my friends from India and my friends from international community, so Alexei, as well as Ojin Trinka, and hand over the mic to the conveners to carry on the activities. Thank you so much. Gagan?
Yeah, thank you, sir. So with this, straight away would request the chairpersons for today, Professor Sangeeta Rawat and Professor Chaturbhuj Rathod, both experienced epileptologists and neurologists, very well accomplished in their fields, to kindly take over, introduce the speakers, and then we would have the talks. I think Alexis is probably joining a little late or something. I mean, I've just sent him an email, so perhaps we could, Dr. Sangeeta, we could start, and Dr. Rathod, we could start off with Dr. Trinka's talk first, and then meanwhile, if Alexis, as and when he joins in, then he can take over the second or the third talk. Yeah.
Thank you, sir. Yes, sir. I think that should be fine. So thank you, Professor Gagan, for the kind introduction. And I welcome all the delegates and all the speakers for this first Indian Academy of Neurology, Indian Epilepsy Society Joint Symposium, which is a brainchild of President Dr. Nirmal Surya and ably supported by Indian Epilepsy Society, Professor Mendi Retta and Dr. Manjri Tripathi. And it is indeed a great pleasure really to have this session. And Dr. Gagandeep has really formulated a very good academic program. The first talk for today will be by Professor Eugene Trinka. And I think the person, people who are working in the field of epileptology really do not require an introduction to Professor Trinka. At present, he is the chairman at Department of Neurology at University of Salzburg, Austria. And all of us are aware of the Salzburg's criteria for the non-cholinergic status epilepticus. And he has been the brain behind those criteria, which was formulated in the Epilepsy Colloquium in 2013, and it has been followed up world over. Professor Trinka received his training in medicine from the University of Vienna and for Hospital for Nervous Disorders at Salzburg, and subsequently he did his fellowship in epilepsy and epileptology at MNI, Montreal Neurological Institute from 1998 to 1999. He has been then subsequently started his epilepsy and EEG this program at University of Austria, and he set up the largest epilepsy clinic and first epilepsy surgery program in the whole country of Austria. He has been a principal investigator for a number of trials on the development of anti-seizure medicine, and one of the most prominent and pioneer active member in the International League Against Epilepsy, and a member as well as the chair and co-chair on the multiple task forces on the regulatory affairs, on the status epilepticus, neuropathology, and drug development. He has more than 300 publications to his credit, and his research interests include focal cortical dysplasia, and as we all know, the status epilepticus. And I think there is no other person better than Professor Trinka to speak on the medical treatment or treatment of the refractory status epilepticus, a topic which is very close to his heart. And all of we have learned this status epilepticus from his publications. So it will be a great honor for all of us to hear from the horse's mouth. So I invite Professor Trinka to carry forward his talk on management of the refractory status epilepticus. Professor Trinka, please.
Thank you so much for your very kind introduction, and I can only congratulate you to this activity to join with the Neurological Society and the Epilepsy Society, because the things belong together and not separate. So I think that's a very good and straightforward activity when you do these educational programs together. So having said that, it's a pleasure to be here. And I, of course, I'm honored by your words and for your kind introduction. What I'm going to do now is to give you an overview, talk about the treatment of refractory status epilepticus, where do we stand? And it's a conceptual framework which I want to convey to you this time. And I'm looking forward to the discussion. These were my disclosures. So first of all, what is status epilepticus? I think most of you are familiar with that, but when we teach neurology, I think it's important to repeat that. What types are relevant? How do we currently approach refractory status? And maybe we miss something, and that's one of the conclusions. So first of all, it's one of the most frequent neurological emergencies, one of the most common causes for admissions to emergency units, 4.5 million at least in the world. The incidence in adults is 36 per 100,000 per year, but it increases steeply when it comes to the elderly. It's around 80 per 100,000 per year. The refractory one, which is the focus today, is a rare cause. It's 7.2, super refractory 1.2 per 100,000 adults per year. And that's something which is, of course, an important number which we have to keep in mind. The mortality is high, between 17 and 38%, depending on the population studied. Less than half of the patients have pre-existing epilepsy. So it's a neurological acute situation. Low anti-seizure medicine levels is one of the causes. but half of them are acute symptomatic, cerebrovascular, traumatic, inflammatory, encephalitis, meningitis, toxic, metabolic, and tumors are the most common causes. So, but there is a consensus that this is a special condition and it's not just longer seizures. So what is it? There have been a classification which came out in 2015, including 2 operational dimensions, T1 and T2, and 1 conceptual definition within one thing. So status is a condition resulting either from the failure of mechanism responsible for seizure termination or from initiation of mechanisms which lead to abnormally prolonged seizures after time point T1. And it's a condition which can have long-term consequences if it's ongoing and not stopped at time point T2, including neuronal death, neuronal injury, and alteration of neuronal networks, depending on the type and duration of the seizure. So not all types of status are equally in their ability to harm the brain. So let's look at the generalized tonic-clonic. T1 starts at 5 minutes, and T2, when brain damage is expected, is around half an hour ongoing activity. In focal status with impaired consciousness, it's 10 minutes at T1, then it's really not likely to stop on its own, and T2 is later. It's estimated to be around 1 hour, and we have increasing evidence by MRI that this is quite a good estimate. With absent status or other status in epilepsy syndromes, we are not sure. So we set it arbitrarily per consensus at 10 to 15 minutes at T1, and it's unknown whether there is a brain damage. So 2 important groups. One is the non-convulsive status epilepticus proper, and non-convulsive status without coma, that's the same. So when the patient is in non-convulsive status, but is not in coma. So this is, I would not say a benign condition, but it's easy to treat. And then we have the comatose non-convulsive, which evolves from a generalized tonic-clonic status epilepticus. And that's the most severe and dangerous form. Both are non-convulsive, but they're completely different background. So it is a condition which can have long-term consequences, and all the definitions are about to recognize T2. Why? Because we want to prevent brain damage. Continuous seizure activity has a high metabolic demand, compensated by hyperperfusion. Disruption of the blood-brain barrier and vasogenic edema is there. We can see this in the MRI. When there is shift to anaerobic metabolism and the metabolic demand of the seizure activity exceeds the hyperperfusion, then of course we have more severe problems, lactate accumulation, failure of sodium-potassium pumps, water influx, and in addition to that, cytotoxic edema, again visualized in MRI. If the status is stopped, reversion of the neural damages can occur, but if it's not stopped, irreversible damage can occur. And that's very often atrophy after a prolonged status. So what is also important are the systemic factors. So it's not only the brain damage in this wonderful graph by Lottmann, it's also the systemic changes, brain metabolism, blood pressure, blood glucose, in the brain, and energy metabolism, which lead to a point of transition here. Excessive muscle contraction leads to metabolic acidosis. Rhabdomyolysis can occur. Hypoventilation, again, increases acidosis, respiratory acidosis, hypoxia. And then there is a catecholaminergic storm leading to hypertension first, at times also cardiac failure, arrhythmia, a capillary leak, hypotension, and then multi-organ failure. So this is one of the events which lead to death. And what is important is the increasing number of status epilepticus which we are going to face, and many of them are refractory. What you see here is the steep increase, and it's more pronounced in women. So it's 89 per 100,000 per year in the women. So it's a an important thing to recognize. So there are two studies, epidemiological studies, looking at the incidence in communities, one from Finland, one from Salzburg. Both have fairly the same results. It's around 3 to 7 are refractory per 100,000 per year, and 0.7 to 1.2 are super refractory. I come to the definition a bit later. But we have Salzburg, we have Finland, but this is a country in the Arctic Circle, Canada, and there's the Kivalo Nunavut population. And this indiogenic population has to travel to the next neurological department almost 2,000 kilometers. Imagine that, 2,000 kilometers when something is going wrong. Europe is a small country compared to Canada and also compared to India. But what they found here in the Arctic Circle is that the incidence is much higher than what we have in Central Europe. So the number is 84 per 100,000 per year, not 39, 84 per 100,000 per year. And the average time from seizure onset to EEG was 3 days. When we look at that, about the causes, it's also that only few people had epilepsy in this region. So most of them are acute symptomatic, only 16% had previous epilepsy. And remember, in our epidemiological study, it was around half of the patients. So maybe when we have a global picture of certain countries, we underestimate it. What types of status do we know, and are they relevant to recognize? So with the definition, also a classification came out, dividing the ones with prominent motor phenomena, tonic-clonic, convulsive, the myoclonic, the focal motor, tonic and hyperkinetic, and the ones where prominent motor symptoms are not observed, it's the non-convulsive group. As I said, one group in coma and the other group without coma. And here we have the absence, the atypical absence status, the myoclonic status, but also focal aphatic status or aura continua, or focal status without impairment of consciousness. So these are the ones without coma. And one thing which is behind that is this concept which you see here. On one side, you have the epileptic brain dysfunction, and you are partially responsive. On the other hand, you have a damaged brain, a structural brain damage, where the status is very often in the comatose and the prognosis is poor. So there's a gradient from reactive persons in status as compared to deeply comatose patients. So please keep that in mind. The types of status which I wrote here at the top of the graph are, of course, the one along this gradient. And on the far right side, where you have, for example, hypoxic brain injury, the majority of the deficits, most of the deficits of the patient, of the brain, is due to the structural damage and only a small part to the epileptic dysfunction. So consciousness, responsiveness was in our concept in 2009, one of the key determinants for prognosis. And when we look at all these different types of status epilepticus, semiological types, we see that some have a high case fatality. CF is case fatality. It's the one without prominent motor symptoms, the non-convulsive, in somnolence, stupor, and coma. So comatose non-convulsive bears a case fatality of around 40%. And it goes up to 60% when it comes from motor phenomena going down to somnolence, stupor, and coma, where only 40% survive. So the outcome of status is associated with its semiology, and the worst outcome are the ones with non-convulsive semiology and deeply impaired consciousness. Good outcome are the ones without impairment of consciousness, plus minus cognitive symptoms, and of course also motor status. So if you look on the left of this graph, convulsive phenomena only, there was not a single patient who died in our series. So the ones where you think it's the most dangerous, it's not. It's the comatose ones which are the dangerous ones. So later on, Simona Latanzi from Italy and our group, they looked at certain clusters in status epilepticus with prominent motor symptoms. We looked at the etiology, at the dynamics, at the EEG pattern, and the treatment responsiveness. And there are 4 clusters. One is the focal motor evolving into non-convulsive with LPDs, lateralized periodic discharges, cryptogenic etiology, and drug resistance. The second is spontaneous burst suppression on EEG, super refractory, progressive symptomatic etiology, and also starting with motor phenomena going into non-convulsive. And third is no LPDs, no periodic discharges, drug responsive, convulsive only, as I said previously, and acute symptomatic etiology. And then we have the focal motor only. So these clusters, EEG, clinical phenomena, prognosis, and drug responsiveness, can also be assessed when you look only at the non-convulsive. But here we added the degree of impairment of consciousness. And what we really can say is, depending on the GCS score, the prognosis is either better or worse. So 3 clusters, GCS low, 3 to 8, spontaneous burst suppression, super refractory, acute symptomatic, GCS 9 to 12, LPDs, unknown etiology, treatment refractory, and GCS 13 to 15, no LPDs, no GPDs, progressive or remote etiology, and treatment responsive. So it goes to a confirmation that we hypothesize that the degree of consciousness is important. But what happens when we treat the patients? Well, we start with the semiology, we classify it, but then it moves on. We start treatment, we have the EEG. With increasing treatment, semiology loses its diagnostic and prognostic value because we give the patient drugs which impair the consciousness. It's a kind of blind flight, or we fly blind, or we use instruments, and the instrument can be the EEG in that period, because we cannot rely on the semiology alone. Reliable EEG criteria are necessary for diagnosis of non-convulsive and for evaluation of the treatment success. So how do we apply this when we approach refractory status epilepticus? We all use a staged concept. We're starting with the early status, treatment with benzodiazepines. You have the T1, 5 minutes and 10 minutes. Then you give benzodiazepines either intravenously, intranasally, buccal, or intramuscularly. If that fails, after failure of first-line benzo, it's benzo-resistant status epilepticus. It's established status, and we have several anti-seizure medicines intravenously available. It's phenytoin, valproic acid, levetiracetam, but we also have lacosamide, brivaracetam, and soon we will have perampanel also as an intravenous solution. In some countries also topiramate. So we have a lot of choices, but we have good evidence for 3 drugs. Once this is failed, this established stage, we call it refractory. So we have 1 benzo and 1 anti-seizure medicine failed. That's the definition of refractory status. And we give usually IV anesthetics. The time frame is around 30 to 60 minutes. And then we can also say super refractory when the status continues despite treatment for 24 hours. And then it's prolonged super refractory and prolonged refractory status. So, but this doesn't happen like in a graph here. So the patient comes in the emergency unit, or it's in the pre-hospital medical setting. You see the patient, caregivers or witnesses, they call the emergency. they have an anti-seizure medicine at scene, they give the benzo there, then the patient is transported to the hospital. You have the second information transfer, you are in the emergency department, then it goes to the epileptologist or neurologist, and you have to do at the same time with a very strict time schedule, take the history, when was the patient last seen well, when did status epilepticus occur first, when did you apply the first anti-seizure medicine, and what was the cause? Yeah, so it's a complex thing, and many people are confused about the complexity of status epilepticus, because you have to diagnose, treat, and find the etiology within the same time. Then when it comes to the hospital, you give the anti-seizure medicines again, and then when it doesn't respond, you move to the refractory stage. And when you move from the ward or from the emergency room to the ward and from the ward to the ICU, you always have an information transfer. So it's very important to note everything what the patient has. Do we have evidence for treatments? Yes, I think we have now good evidence for all the benzodiazepines which we give in the first line. For the 3 intravenous drugs, levetiracetam, phosphonatoin, and valproic acid, they are equally effective. This is the ESET trial, which is probably the most outstanding trial in epilepsy. 50% of those who were benzodiazepine resistant responded to these intravenous drugs. And there was no difference also in the adverse effects. So this is why we have quite homogeneous guidelines. These are the US guidelines. You have the stabilization in the early phase, the search for diagnosis, the quick application of benzodiazepines. Then you move to the anti-seizure medicines intravenously. And if not, you are refractory. And now we have the problems because we are in an evidence-free room. So far, so good. But what do we do with the refractory, and do we miss something when we look at the course of status? Well, first of all, we mentioned 3 anti-seizure medicines, but we didn't mention phenobarbital. So this network meta-analysis on benzodiazepine-resistant status found something interesting. So the basis of this network meta-analysis is that you can compare the drugs indirectly. So if A is better than B and B is better than C, it's also logic that A is also better than C. So this is the syllogism from Aristotle introduced, and it's very useful when you look at this network meta-analysis. What you find here, and I highlighted it, is that in every comparison where phenobarbital was used, it was better than the comparator. Every comparison was won by phenobarbital. So phenobarb was superior in this network meta-analysis to phenytoin, valproic acid, diazepam, levetiracetam, etc. in terms of status cessation. But it had the greatest probability to achieve seizure control and seizure freedom, and the best tolerated was valproic acid and lacosamide. But I mean, we have to think about this. Phenobarbital was not included in the ESET trial. So maybe we miss the best drug to prevent refractory status. Second point, we underdose in the first line. The more we underdose, the more often we get refractory status. So the best treatment for refractory status is its prevention. And that means high doses, adequate doses in the early phases. In our sensor register, more than 1,000 episodes, the first intravenous drug was underdosed in 76%. In 76%, it was underdosed. And what came out is that you see here. So after 1 hour and after 12 hours, you see that when you start with levetiracetam only, status goes on. When you give benzos or in combination benzos, at least 40% are responding. And in the clinical trials where you have the high doses, it's 60% responding. And after failure of benzos, 50%. So in the reality, we are worse than in the clinical trials. We have to increase the dose when we treat status. Third point, identify the cause, and that's extremely important. Every neurologist knows when someone comes in with a hemiparesis, we have to identify the cause, whether it's stroke, whether it's tumor, whether it's bleeding. And the same with status epilepticus. We have the big five, as we see here, and that's within hours to identify. But when we do not have any cause like that, we run into trouble. And that's why NORS comes in. It's the new onset refractory status epilepticus. And there is one syndrome related to that. It's a febrile infection related epilepsy syndrome. And when you dig into these etiologies, you will find most often autoimmune encephalitis, non-paraneoplastic or paraneoplastic in the adults, or rare infections in the children. And that's about half of the cases. Nota bene, the other half remains unexplained. So that's an enigma. When we look at what has been reported in the literature, well, you know, infectious disease tests, autoimmune panels, genetic testing, some do skin biopsies, some do this, some do that. So it's a mixture. There's no consensus what is the right approach, and this is what we have to work on. This is a rare but very important condition because the mortality and morbidity is high in the survivors. We have to make a standardized approach here. Why it is important? Because we treat differently, not with anti-seizure medicines, not with anesthetics, but in addition to that, with immunoglobulins, rituximab, cyclophosphamide, plasma exchange steroids, all these immune drugs come in. On top of that, we have the anesthetics, barbiturates, propofol, midazolam, and we don't know which is the best. But what we do know is that anesthetics are, you know, these are poisonous drugs. These are dangerous drugs, especially phenobarbital or thiopenton. And we see in this 6-year cohort study from Raul Suter that significantly more patients die when they have intravenous anesthetic drugs as compared to those who do not. And the ICU stay is also significantly longer. It may be because these are the more serious status, but it may also be the toxic effect and the burden which you apply to the patient when you give him toxic drug. So I said, when the patient is sedated or has a treatment, we are in blind flight. And the only thing what we can do is look at the EEG criteria, and the Salzburg criteria have been mentioned. They work quite well, but they are based on EEG, surface EEG, and the frequency of discharges. But we must not forget the clinical side at the beginning, at the diagnosis, but also during the course. Because what happens when we have periodic discharges, we have an increased metabolic demand, which can be assessed very nicely with PET. It has been shown that the frequency increase of the periodic discharges by more than 1 Hertz increases the metabolic demand by 300%. There's a linear correlation. The faster you go with the LPDs, 2.5 Hertz is an enormous metabolic demand. What we don't see, what we miss, is what happens in the brain directly. And these are recordings from the cortex. You have spreading depolarizations and spreading seizures, either once where, you know, the cortex depolarizes or moves across the brain surface. And these depolarizing events in critically ill patients, they correlate with the prognosis. So these are not touched by standard anti-anesthetic drugs. But ketamine, which is used in refractory status epilepticus, is a racemate. We use the S-ketamine. It's renally excreted. It binds to the NMDA glutamate receptor, to the ionotropic. You can apply it intravenously, but also intramuscularly. It's a very well tolerated drug, has no cardiac depressive events. It works in refractory status epilepticus in around 60%. It brings the patient out of status. There are several studies, and there's now a study planned in the USA. But what it does in addition is it reverses and it blocks the spreading depolarizations, which are associated with a poor outcome, which you don't see in the surface EEG, but which have an impact on the brain. So we have to go from the surface EEG one level deeper to the cortical EEG and look at the spreading depolarizations. And ketamine is the drug which is useful here. So for my opinion, even if we don't see it in the continuous EEG monitoring, we should start earlier with ketamine when we deal with status epilepticus. And later in the stages, and I mentioned NORS, we treat with immune modulators. And one of the substances, and there's no randomized controlled trial, one of the substances is anakinra. It is an interleukin-1 receptor antagonist, and it has been reported to be useful in febrile infection related epilepsy syndrome or in NORS. Tocilizumab is an interleukin-6 blocker. Again, here a study from Korea, very successful, very nicely published, both in excellent journals. My own experience is that these drugs are dangerous and we have to look at the side effects. They have a lot of immune suppressive side effects, and there's no compelling evidence that this should be the standard of care in all cases. In selected cases, yes. One thing which is interesting, and again, studies are coming and are planned, it's allopregnanolone and ganaxolone. These are neurosteroids binding to the extrasynaptic GABA receptor. Allopregnanolone and ganaxolone bind to the same receptor, and there are now studies using ganaxolone in refractory status epilepticus. One in the US and one in Europe is coming. So when we want to bring that to a concept, we have several things to consider. First of all, it's the burden of disease concept, burden of status concept. Remember the graph which I showed you previously. You have a structural brain damage or a metabolic brain derangement, and that can be low or this is very high. And then you can have, of course, the functional reserve. What the brain can fight against status and against the structural brain damage. That's a functional reserve. It can be low, moderate, or high. When this is decompensating, well, it can be, it's a gradual process. It's not one switch. It goes from the mild decompensation, moderate to severe. So then it comes to the burden of status epilepticus. What is in addition the burden of status epilepticus in addition to the structural damage? It can be low or it can be moderate or high, as I showed you, the metabolic demand, which increases or which uses up the functional reserve. The success of treatment can be high, moderate, or none, which can partly reverse it, but it can also be toxic to the brain and lead to a decompensation. So what is important is that all three factors, the burden of status, the success of treatment, the burden of treatment, sum up with the impact burden, which eventually can threaten the patient when you overtreat or not treat the underlying cause. So the gain of treatment can at best reverse the burden of status. The burden of treatment can, depending on the aggressiveness, as I showed, overshadow the gain of treatment. And the smaller the fraction, the functional reserve is, the earlier the stage of decompensation. And this is a quick example. I have two examples and then I'm finished. So this patient, 51-year-old, clearly fulfills the Salzburg criteria for non-convulsive status epilepticus. You see the CT. There is no lab value which can explain that. What we see here is that the EEG findings are worse than what you expect from lab and CT. So there's an electroparaclinical gap, and the EEG changes are not explained by the underlying disease. So there's a functional component which we can reverse. So when we treat this patient, the other case here is it doesn't fulfill the criteria. It's triphasic waves, and And what you see clearly is you have an explanation for these triphasic waves. You have the renal failure. And what you see here is that the EEG findings do not are not more than what you expect. You expect that, and you don't have to treat this with anti-seizure medicines. So the EEG findings do not exceed what can be expected from the lab values. So we have to take everything together. It's the EEG, it's the clinical and the paraclinical evidence coming from MRI, lab toxicology, and then make a conclusion when to start treatment. This is a non-convulsive status in coma with periodic discharges not fulfilling the Salzburg criteria. We treated that, patient improved, and we have another paraclinical evidence that we have hippocampal swelling in the left hippocampus leading to an atrophy. So this was status epilepticus based on clinical and MRI diagnosis, supported by periodic discharges in the EEG, not fulfilling the Salzburg criteria, but still being status and treated. And here we have the puzzling situation of encephalopathy, non-convulsive status on the left, interictal on the right. So the Salzburg criteria do not work in this case, they were not fulfilled. But when we look at MRI perfusion, we see a hyperperfusion bilateral in the frontal areas, confirming that this is status epilepticus. So to conclude, it's one of the most common neurological emergencies. There's a huge geographic variation. The definition tells you when to start treatment and provides a framework for de-escalation and escalation. Classification is based on semiology, etiology, and EEG. So these are biological classes which go together in clusters when we come to status. High-class randomized controlled trials and clinical practice guidelines are available or in statu nascendi. We have to identify the causes for these rare superrefractory or Norse syndrome. We need collaborative research. What we are missing, well, non-adherence to the guidelines increases the risk of refractory status. Diagnosis is at the moment very much biased towards EEG. And the impact of burden concept, consider structural, functional gap and burden of treatment. Cordially invited to the next Status Epilepticus colloquium, and I thank you very much for your attention.
Yeah, thank you, Dr. Trinka. I think it was excellent talk, and your slides were just amazing. I think each slide had so much of material, and it was really a feast for us to hear you today. Thank you very much. And I think question answers will be at the end when we finish the other two speakers. So now we move over to Dr. Alexis. Sir has joined. Can I have his slide? So we all know he's a famous pediatric neurologist. He's a director of pediatric clinical epileptology, sleep disorders, and functional neurology at Hospital of Lyon, France. Is as a scientific coordinator of epilepsy unit at San Dionis Hospital of University of Barcelona, Spain. He's the coordinator of the European Reference Network for Rare and Complex Epilepsies, ER and Epicare, elected member of the current ILA Europe Commission. He has received EPNS ICARDI Award for Excellence in Pediatric Neurology, ILA Ambassador Award, and the European Epilepsy Education Award. And he's an honorary member of the Academia Ibermania at Neurologia Pediatrica. He was the editor-in-chief emeritus of the ILA Journal of Epileptic Disorders and associate editor of the European Journal of Pediatric Neurologists. We all know his work on neurophysiology and pediatric neurology. And today we are really going to be lucky to have such a good speaker again with us. So welcome, Dr. Alexis, and we are happy to hear you. Okay.
Okay. I hope you hear me well.
Yes, we can hear you.
Great. Thank you, Professor Rawat, for this kind introduction. My sincere apologies to everybody for being late, but I had the wrong hour on my agenda, which explains why I didn't appear. I was waiting for the time to come. Everything was ready. And I'm sorry for the stress created.
No, no worries. No worries.
Okay, so I'm really happy to be with you. I would be happier if it was really with you, but Joint Symposia are for this. I was asked to discuss an approach, a case discussion of Dravet syndrome. I did it in a quite different way of what we are usually doing. I hope you will like the way I approached it, in the sense that I built it up in forms of questions that are very simple, and you can send your answers in the chat. And of course, I will comment every question that I will be doing. I hope that my slides are moving. So this is the case of an 8-month-old boy who's experienced his first febrile seizures at the age of 6 months. Now, according to the emergency department, let us admit you are the doctor of the emergency department, he had a left-sided hemiclonic seizures with jerks that lasted approximately, reports the family, 35 minutes. Now, at the emergency room, clinical assessment, biological screening, and the CT scan were normal, and they asked for an EEG. Now, 2 weeks later, before having his EEG, the parents called immediately following a second event. This time, the clonic jerks were right-sided, and that lasted more or less 45 minutes. And of course, 15 minutes after the end of the jerks, the clinicians at the emergency got the impression of a moderate right upper arm deficit that persisted for approximately 10 minutes. Now, let us try and move to your turn now. I must move. So, from the statements below, which are not suggestive of a Dravet syndrome, you can, of course, put just the numbers in the chat or think it on your heads, because I will give you the answers in a minute. So the possibilities are: the patient is a boy, the onset occurred before 12 months of age, prolonged unilateral seizures occurred within a febrile context, recurrence occurred within a short interval, there was no family history of epilepsy or epileptic seizures, neurodevelopmental skills were normal, CT scan was normal. So my question to you all is, which of the 7 points here are not suggestive of a Dravet syndrome? Well, I suppose you all know the answer, or I hope you know it. But again, I give you 1 minute to put in the chat so I can check later on if you were aware of this or not. So, well, Gagandip answered well, but this I knew. And number 6, someone else said. So, okay, let me try to give you the correct answers. My turn now. In fact, what is not suggestive of a Dravet syndrome is the patient is a boy, because there is no predominance of boys or girls in Dravet syndrome. Usually the syndrome begins before the age of 12 months. And the other thing that is wrong as a statement is that there was no family history of epilepsy or epileptic seizures. We will see later on the genetics of Dravet syndrome, but globally, you don't have to have a family history of epilepsy to have a Dravet syndrome. All the other statements, of course, are correct in the sense that the syndrome was described with prolonged unilateral seizures within a febrile context that occur in a rather short interval. You have the first episode, and a few weeks later, the child comes back. And usually, not usually, always, the CT scan is normal. Now, let us move again to your question. Now, during the natural course of Dravet syndrome, different types of seizures occur, this we know, okay? Which from the list below are not observed. So you have prolonged asymmetric febrile seizures, focal unilateral clonic seizures occurring on both sides, tonic-clonic seizures of generalized onset, tonic seizures, generalized myoclonic seizures, atypical absences, focal seizures, obtentatious status, and epileptic spasms. So again, the question here, which of the numbers here, 2 or 3 numbers, are not observed in a child with Dravet syndrome? Okay. Well, those that they're answering answer correctly. The others don't answer. So we can assume they agree. So yes, these are the correct answers. Tonic seizures are not described in Dravet syndrome, and the same applies to epileptic spasms. All other seizure types of seizures that were on the list can appear in the course of the disorder, and that is important. All of them do not appear at onset. As we said at the first slide, these are usually unilateral clonic febrile episodes. Myoclonic seizures may appear later, atypical absences also. And of course, you can have tonic-clonic generalized seizures, and you can have also focal seizures with or without secondary generalization and episodes of non-convulsive status. But you don't have tonic seizures and you don't have epileptic spasms. And I'm always happy to show this diagram that I designed for Jean Ecardi when I was a child, where he, well, almost a child, where he asked me to describe or to situate epilepsies with drop attacks, including Lennox-Gastaut syndrome, for example. Here, as you can see, the spectrum of diseases with myoclonic seizures. Remember, Dravet was initially named severe myoclonic epilepsy of infancy. You see that you have different types of seizures of what we described, and particularly the tonic seizures are in a small part of patients with myoclonic atonic epilepsy. This is the myoclonic variant of Lennox-Gastaut syndrome, a term we don't use anymore. And at the end of the spectrum, the Lennox-Gastaut syndrome, where there, yes, you have tonic seizures that appear, and also you have the EEG translation. And in terms of etiology, when you are on the right side of the spectrum, the benign myoclonic epilepsies, usually the causes are purely genetic. And the more you move towards the Lennox spectrum, you see that you have different diseases, focal cortical dysplasias, lesions, tuberous sclerosis, and so on. But, and that is the important point, what is now on the right top of the slide clearly shows that the Dravet situation is completely different in terms of major types of seizures. First of all, because of the issue of fever, and of course, the unilateral chronic seizures we mentioned a minute ago. Now, let us try a little bit of EEG. This is a bit harder. You decide to perform a video EEG or EEG during wakefulness and sleep. Your patient still has 8 months. Which of the following could you expect in the EEG report? Background at around 5-7 hertz during wakefulness, background at around 2-3 hertz during wakefulness, theta activity of 4-5 hertz over the Rolandic and vertex area awake, symmetric background during wakefulness, generalized spikes elicited by intermittent photic stimulation, focal epileptiform abnormalities, symmetric spindles during sleep, or vertex spikes during sleep. I will leave it a minute more because I fully realize that this is, of course, a more difficult to answer question. So which of those you would expect on this first EEG of your child with suspected Dravet syndrome, as we discussed a minute ago? Let me see who dared answering. Oh, many of you, good. So 1478, 1357, 2, 3, and 6. Okay, let me give you the answer. Most of the answers we have here are correct, but I have to be able to move. Yes, in fact, these are the correct answers. As you see, the majority of a normal background EEG at a child of 8 months old is what you usually find when you first perform an EEG to a Dravet that just starts. Of course, you can have generalized spikes elicited by intermittent photic stimulation, and this will be even more pronounced some months later, but all the rest is more or less what you could expect on a normal EEG at that age, because the Dravet syndrome EEG becomes abnormal later in the course of the disorder. So this is what you need mainly to remember for the EEG in order not to miss the diagnosis at the beginning. The EEG in Dravet syndrome evolves as the patient grows up. Different features can be noted depending on, first of all, the interictal semiology at onset is usually normal for age, both on awake and sleep. In some cases, you may have a rhythmic theta activity, as someone answered, of 4-5 hertz over the Rolandic and the vertex area. And there is a nice description in an epilepsia paper of 2011 by Michel Bureau and Bernardo Dalla Bernardina on the electroencephalographic characteristics of Dravet syndrome. It didn't change much, so you can always refer to this publication. By the way, I have absolutely no problem giving the PDF of my slides at the end if you want to have the references. And then the interictal EEG evolves when we enter the steady state of the disease. While awake, the EEG background activity remains normal or slightly abnormal in 50% of the cases. But in the remaining cases, it starts becoming slow, poorly organized, and of course, this depends on what age period you perform the EEG. In some cases, you may still not have epileptic abnormalities, but when they are present, they are usually spike waves and polyspike waves that are multifocal. So, as for the sleep EEG, is usually well structured again when we enter the steady state with a physiological pattern and cyclic organization, except when you have severe seizures occurring during night. Now, an easy test for you. Is this EEG at a child of 13 months compatible with the diagnosis of Dravet syndrome? Here, the answer is yes or no. The first answer that I received was no. Who else wants to try? That someone wants to try and answer what it is, if it's no? Well, it's difficult. Yeah, you do have the interval. Okay. The correct answer, yes, is no. This, in fact, is an EEG pattern of hyperarrhythmia in a child with West syndrome. I didn't show you an epileptic spasm, of course, but as you can see, it is much more abnormal than what one would expect to see in a child suspected to have Dravet syndrome. Now, let us move a little bit to the etiology. All the genes that are below have been reported as potentially related to genetic epilepsies, with electroclinical characteristics that can be evocative of Dravet syndrome. Which two are most frequently associated with Dravet syndrome? One of the two is easy, the second one may need some background knowledge, but I suppose that the answers will be mostly correct. Okay. The panelists at least answer well, which is reassuring. So, oops. These are the good answers, 5 and 11. Of course, the SC1N1A is described as the main genetic abnormality in Dravet syndrome, and the other one is PCDH19 with a more or less similar phenotype, and I will say the differences in a minute. So, Again, most of the genes proposed here are reported to be associated with Dravet-like. However, many are either anecdotal or appear to be associated with a different specific clinical picture. And on the other hand, you don't have one mutation, but more than 700 SCN1A mutations that have been reported with Dravet syndrome. Now, the reason I insist on this is also to remember making a comment the other way around. You can have an SC1A mutation without necessarily having a patient with Dravet syndrome. So you still need to know the clinical semiology, the EEG pattern, and the evolution of these patients. This, from my point of view, applies to all genetic epilepsies. You know that the phenotype-genotype correlation is not always one-to-one. That, of course, once you identify a gene defect, you enlarge the clinical phenotype, but you still have to remain with the core symptoms present. And in other cases, of course, using this approach, you will have that other genetic abnormalities can have a quite similar phenotype. So going back to this issue, these are the characteristics of SCN1A in terms of etiology. It is linked to a mutation in 85% of cases, affecting a sodium channel. Most of these mutations are de novo, but keep in mind that familial mutations occur in 5 to 10% of cases and are usually missense mutations. Mutations lead to truncations in 40% of cases and are missense in 40%, with the remaining causing site changes. Now, nowadays, there are several families reported to have more than one child affected with Dravet syndrome. And again, this is important for genetic counseling. I remember when I was much younger, we were much more reassuring with the family when they had a child with Dravet syndrome. Today, personally, I prefer sending them to my geneticist, or at least to raise the issue that there is a risk of having a second child. And in epileptic disorders, you have a very nice paper from Nicole Chemali discussing the electroclinical features of SCN1A compared to PCDH19. And these are the differences. The main distinctive features between SCN1A related Dravet syndrome and PCDH19 is what? First, PCDH19 is related to girls with early onset febrile and afebrile seizures that present clusters of focal seizures and episodes of status epilepticus. So you see that the clinical picture has some common points, but not that many, which are of short duration, and there is globally a less severe cognitive outcome of the PCDH19 when compared to SCN1A patients. Which brings me back to my previous diagram. And the reason I introduce it here is that because I will talk about treatment in a minute, there is now a tendency from the companies to do studies for different reasons in Dravet patients with new drugs, and then in Lennox-Gastaut. Both the regulatory agencies and sometimes the companies don't seem to realize that we are talking about two completely different categories. Dravet syndrome is a disease. Dravet syndrome has a specific electroclinical picture and has one major etiology, SCN1A, and I discussed the smaller number of patients with other things. Lennox-Gastaut syndrome is a garden variety of etiologies. You can have a Lennox-Gastaut syndrome for a number of reasons, going from anoxic ischemic encephalopathy to tuberous sclerosis and to many other etiologies. So Lennox-Gastaut will never be one disease. Lennox-Gastaut is an electroclinical pattern that serves you to better understand how to handle the epilepsy or to diagnose it, but the background disease may be completely different. And you all know examples of, for example, again, tuberous sclerosis and Lennox-Gastaut syndrome, or anoxic ischemic encephalopathy and Lennox-Gastaut syndrome, and so on. So we need to keep this difference clear in our heads, I believe. Now, one more quiz for you. Which epilepsy syndromes or etiologies may manifest around the age of 1 year, 8-12 months, in which fever may ultimately be a trigger of the seizures? And you have 8 examples: vitamin deficiency, infantile spasms, focal lesional or MRI negative epilepsy, the mitochondriopathies, tuberous sclerosis, childhood absence epilepsy, Panayotopoulos syndrome, and Gastaut type occipital epilepsy. So which of those manifest at the age of 8-12 months and can be triggered by fever? Keep in mind that the slide introduces 2 concepts, of course, the fever issue, but also the age issue. So keep it in mind, because age is an extremely helpful indicator when you try to make a diagnosis. And I strongly advise you to read the recently published nosology papers of the ELIE, including the methodology one from Elaine Wirrell, where you will see how important it is to have your reasoning with age concepts and see how it goes. So, which of those may be triggered by fever? These are the answers. Vitamin deficiency can be triggered. This is an age that children may have fever. It's difficult to be sure all the time. Of course, focal lesional or MRI negative epilepsies, you can have a focal epilepsy at that age, and you can have a mitochondriopathy or a tuberous sclerosis. So some of the answers were good. No doubt that the mitochondriopathy is one of the most important you should know. The others are infantile spasms are not triggered by fever, and the other 3 syndromes are much later in life. So you do not look for these 3 syndromes if you have a child of 8 months old that has a febrile, a convulsion in a febrile context. Of course, going back to Dravet, the main difficulty is to make the difference between a unique, prolonged febrile convulsion and a Dravet syndrome. But again, every prolonged febrile convulsion is not a Dravet syndrome and vice versa. You need to get some more elements, which are mainly clinical. It is mainly the evolution of the child and, of course, the duration of the episodes that will give you some hints and some answer on this. Okay, let us move to treatment now. The diagnosis of Dravet syndrome with SC1A mutation was confirmed, and you wish to advise the referring pediatrician on the first anti-seizure medication to be prescribed. Which of those below are documented as possible first choice drugs? On purpose, I didn't say are used because I know the licenses are not the same in all countries, but there are, let me help you, 2 of them that are documented as first anti-seizure medication that could be given in patients with a Dravet syndrome. Okay, the answers are good, although there was a trap at the middle. Those that are indicated as first choice, in fact, are valproate and clobazam. Stiripentol, of course, has an indication in Dravet syndrome, but it is not indicated, even in France, where it started as the first anti-seizure medication. And being pragmatic, when the child comes with a 35 minutes unilateral chronic seizure, if you strongly suspect, even if you strongly suspect a Dravet syndrome, you will not put as a first choice stiripentol. You need to be a bit more reassured with drugs you know better. Clobazam and valproate have this indication. They are both large spectrum drugs. Of course, one of the 2 is a benzo, and the stiripentol treatment would come later. I will say a word in a minute. Now, in clinical practice, what other drugs are used? Topiramate has been reported, not in a trial, but it has been reported to control convulsive and focal seizures relatively well. There are some case reports, quite a lot, that topiramate can help in the treatment of Dravet syndrome, but it is not a first choice. Again, there is no indication as a first choice. Lamotrigine was reported, as you probably know, to worsen or aggravate children with Dravet syndrome. The truth, from my point of view, is that this is true for young children with Dravet syndrome. Later on, when you have a patient, when you're an adult neurologist and you have a patient with Dravet syndrome, I don't know, 14 years old with generalized tonic-clonic seizures, I would not hesitate a minute to try at some point lamotrigine and see if I control the generalized tonic-clonic seizures. This is probably an age effect, very difficult to study, but the response to the treatment or the risk of aggravation is not the same when you are a young child and you with Dravet and they give you lamotrigine, or when you are a bit older. Now, the carbamazepine is excluded. Carbamazepine is excluded because it can really aggravate the myoclonic seizures and the atypical absences. So not only it is not a first drug to be chosen, but even later should be avoided unless you just want to give a desperate trial and you tried everything else and you don't have a treatment and you may think it can help you. I can hear this. Now, which brings me to the 3 or 4 concluding slides on how we evolved. I mean, the story of Dravet is a very nice story that illustrates how complicated it is for rare diseases to better know the disease. It was described 30, 40 years ago by Charlotte Dravet as severe myoclonic epilepsy of infancy. The name changed with time. Ecardi at some point suggested to call it polymorphic epilepsy of infancy because he was saying that it's difficult for him to listen that the syndrome is called severe myoclonic when some of the children don't even have myoclonic seizures. Anyway, with time, we were able to identify the genetic etiology behind it. The genetic etiology took another 10 years, allowed to better phenotype the different entities near or with a similar clinical picture, which brought to better treatments. And as I said a minute ago, yes, stiripitol clearly is a drug indicated as an add-on treatment today. Its main action is not that it suppresses the seizures, but it definitely reduces enormously the duration of the prolonged clonic events. They go down from 30 minutes to a minute, which is, of course, very important, particularly in a period of neurodevelopment. More recent drugs, you all know them. There are good trials today on the indication of Epidiolex or cannabidiol for Dravet syndrome. And the same applies to an old new drug, a repurposed drug, fenfluramine, which again, the studies are really reassuring, very interesting. And also the issues related to past use of the drug as an anorexigenic and the risks of cardiac disease were eliminated, and they were very well studied in these trials. And we should not be afraid if we have the authorization to use this drug. So here you have just a brief summary of how it goes and what I said about the treatments a minute ago. Keep always in mind that these children, we may not be able to control everything, so do not overload them with drugs. We may need to, one, control episodes of status or reduce them to the minimum, decrease the seizure frequency, and keep in mind that these are patients of a high risk of SUDEP. It's one of the rare syndromes in childhood with the risk of SUDEP. You have very well published protocols. This one was published by Ellen Cross for the procedure to how to treat prolonged seizures, which is probably what someone would do when a child with Dravet arrives. These are not, of course, all randomized controlled trials, but it is what it's usually done. And as you can see, you mainly have some benzos at the beginning, and then you go to valproate. I will not dare with someone in the audience like Eugen Trinka starts talking about how to treat prolonged seizures, you just heard him, and I would like to thank him for taking over because I was late. And of course, there are recommendations that evolve with time. These are the ones published by the North American Consensus Panel. Again, you find the same things, valproate and clobazam, addition of stiripentol or topiramate, or ketogenic diet. There are some reports. And then you go to a garden variety of drugs, and you may also need to consider vagus nerve stimulation if the others don't work. It will change with time. That is why all these are recommendations. Now on the right side, we added CBD, we added fenfluramine, depending on if it's approved or not. And hopefully this will go even further with more targeted therapies, or let's say gene therapy for these diseases. Now, this is my last slide, and you can flash or use the QR code because I need also to do some publicity to the European Reference Network for Rare and Complex Epilepsies. The case I presented here is the one of Jules, 8-month-old, Dravet syndrome, which is on the e-learning modules of EpiCare. All these 6 cases are available for free. They are interactive, and you can try building up yourself and find out what you know about those. And they are also incorporated to the ELAE Academy. And with this, I would like to stop sharing my screen, but of course, I would like to thank the organizers, and particularly Gagan Tripathi, who invited me here. Thank you again. I can't hear you. I hope I'm not the only one.
Sangeeta, you're muted.
Thank you very much. I think it was really relearning of the Dravet syndrome, and really enjoyed your presentation, and your question answers were really puzzling. Good. So now we move on to our last speaker, Dr. Sita. She is very well known in our Indian now as well as in international for a famous epileptologist. She's at Krishna Institute of Medical Science, Hyderabad, India, and she has a special interest in epilepsy and epilepsy surgery. And she's done more than 1,000 epilepsy surgery patients under her, more than 100 publications in national and international journals, and contributed several chapters. She received best paper awards in international and national meetings, and she is presenting interesting case. So over to you, Sita.
Thank you, Sangeeta. So after listening to the 2 excellent lectures, I'll be presenting an interesting case. My slides are seen?
Yes, we are seen.
Yeah. So quickly, I'll present a very interesting case which we encountered 6 months ago. This is a 17-year-old boy who is right-handed with the first child born of a non-consanguineous parentage with full-term normal delivery with no perinatal complications, with the normal development. He had one typical febrile seizure at 3 years of age with no history of encephalitis or trauma, and there is no family history of epilepsy. His development was normal, but the scholastic performance was poor, and he had no behavioral disturbances at any time point in the before presentation. And when he came, he has no neurocutaneous markers, no dysmorphic features, and his neurological examination was normal. And his seizure started from the age of 7 years, the first habitual seizure, with the duration of almost 10 years. He's 17 years now. The semiology wise, looked very simple when he came to the OPD. He has no aura. He develops brief behavioral arrest followed by repeated jerking of the head along with both upper limbs with brief bimanual automatisms lasting for 20 to 30 seconds. So clinically, we thought possibly it's a myoclonic absence epilepsy. And he says that briefly he's not aware, but immediately after the event, he could immediately respond. When it started, initially the seizures were 1 to 2 per day. But for the past 2 years, the seizure frequency has increased remarkably high, around 5 to 10 per hour in the awake state, so that preventing him from doing any activities in the day-to-day. And he gets almost around 20 to 50 seizures on various days, and he never had any bilateral tonic-clonic seizures. And Jesus predominantly in the awake, but sometimes he gets up in sleep and he does this head nodding. And over the past 10 years, he had a maximum Shiza frequency for 5 days and never had any status epilepticus. When he came to us, he was already tried on multiple drugs, and looking at thinking it's difficult to treat absence epilepsy, that is possibly epilepsy with myoclonic absences, we started him on valproate with lamotrigine and clobazam, and later added even perampanel, but without any significant change in the Shiza frequency. He already underwent a CS of glucose, possibly thinking the GLUT1 deficiency, but genetic testing was not done. And we got a neuropsychological evaluation, which just showed that his IQ is 77 with borderline intelligence without any other significant findings. And his quality of life was poor because of the frequent seizures. And if you look at the interictal EEG, this is the interictal EEG, which shows occasional spikes on the left temporal chain. But if you see, most of the discharges were generalized. These are the high amplitude polyspike and wave discharges, preceded possibly some left hemispherical onset. And also the generalized spikes were followed by some left temporal slowing. But this is the interictal EEG, which shows flurry of events. Possibly this is a interictal corundum because of the frequent seizures. So we see a typical 3 Hertz spike and wave discharge with an abrupt onset and an offset. And this is again the rest of the interictal EEG, with preceded by 0.2 seconds of some focal discharge coming from the left temporal. So overall, he has continuously the generalized discharges with occasional focal epileptiform discharges, predominantly on the left side. Then coming to the ictal semiology, I'll just show the semiology here. Can you see the video, Sangeeta?
Yes, we are able to see the video. Yeah.
ఎంతమంది పేరు నాలుగు చూపిస్తున్నానా కుర్చీ పైకి అడంసే పైకి లేపు ఏంటన్నది ఇది
So what we have seen is sudden bending of the head forwards with head nodding along with mild abduction, extension of both the hands, suggestive of a possibly myoclonic absence. Along with he has automatisms of the hands, left followed by the right. And this is the corresponding EEG, which again showed a high amplitude, predominantly bilateral frontotemporal amplitude predominance, and also in the parasagittal leads, again with abrupt onset and again abrupt offset. Like this, we have recorded a very high number of seizures within 1 day. And so the summary of this case is a 17-year-old child with onset of epilepsy from 7 years of age, with recent increase in the seizure frequency with multiple daily seizures without proper response to appropriately tried anti-seizure medications. So the diagnosis was epilepsy with myoclonic absences. Because he is refractory, we got an MRI done. The MRI brain has shown, surprisingly, a right insular lesion, possibly a focal cortical dysplasia, typically clearly involving the right insular cortex. This is on the flare as well as the T2 images, the sagittal images. So the lesion is very clear cut. So then there was a doubt whether this was really responsible or it is a coincidence, because almost all the seizures are generalized seizures, but MRI is showing a focal abnormality. So we just went ahead with a further evaluation. The FDG PET, as expected, will show any lesion is there, it will show a hypometabolism. So there is a right insular hypometabolism, both in the coronal as well as in the axial images. We can see very clearly corresponding to the lesion, there is a significant hypometabolism on the PET scan. Then we were not sure whether it is responsible or not. So we tried to do an ictal spect almost 3 times. In one, it was almost 30 seconds. duration, because most of the events are 15 to 20 seconds. So again, it did not give any information except for the hypoperfusion, which is even during the ictal phase, it showed some hypoperfusion in the right insular region. So again, it was not helping. So to summarize, he is a 17-year-old child with drug refractory epilepsy with a high seizure burden in the recent past 2 years. Interictal EEG, though, showed generalized 3 Hertz typical spike and wave discharges, occasional left temporal, and also right hemispherical focal discharges. Semiology is very clear-cut, a generalized semiology, which is a myoclonic absent seizures with some bimanual automatisms, which can be seen in the absent seizures. And the ictal EEG again showed typically 3 to 3.5 Hertz spike and wave discharges. MRI showed a right insulo-opercular focal cortical dysplasia because of hyperintensity, possibly a type 2, with the FDG PET showing a corresponding hypometabolism and ictal spec not contributing. So we thought so the questions now are, is it epilepsy with myoclonic absences due to an idiopathic myoclonic absence epilepsy associated with the incidental focal cortical dysplasia, or is it a symptomatic myoclonic absence epilepsy secondary to focal cortical dysplasia? So should we go for any surgical intervention or not? So should we go ahead for an invasive evaluation like an SEEG or directly go for a resection? Sangeeta, can we have some comments here or should I go ahead? Sir.
The faculty or anybody would like to say anything? They can put it in the chat box. I think, Sita, you have to go ahead. Everybody's confused what to say.
Agreed. So we also had a lot of debate, and then so finally we discussed with the family and went ahead with an SEEG plan. So our hypothesis at that point was, so it is well known that frontal lobe plays an important role in the generation of generalized seizures, both in juvenile myoclonic epilepsy as well as in absence epilepsy. So with that, we thought that we should cover the frontal lobe well to identify whether the anterior insular is spreading to the frontal lobe. So we have implanted in the insula, everything on the right side, anterior posterior insula, and we covered the cingulate, and also one in the hippocampus, and also the right mesial frontal lobe, because the mesial frontal networks are responsible for the generation of the absent seizures through the stimulation of the thalamocortical networks. So this is the plan. So actually, and after this is the interictal recording, which shows a continuous discharges coming from the mesiofrontal networks and also from the anterior as well as the posterior insula. So this is the interictal, again another interictal page. So this is during the myoclonic, when we recorded those 15 to 20 seconds events, we could see clearly the discharge, the active, the ictal onset is from the anterior insula and then spreading to the mesial frontal chain. So this is continuation. So the seizure lasted for about 24 seconds in this. So again, if you can see during the SEEG, the fast activity is coming from the anterior insula for about 2 seconds, and then with a spread to the frontal electrode, which is in the mesial frontal, going through the frontal pole. So again, another event of the SEEG, confirming the same. So finally, we thought that this is a possibly epilepsy with myoclonic absences. And this patient underwent a resection of, that's what the diagram which I have shown. Yeah, so this whatever marked in pink is the ictal onset from the insula, which is spreading to the, this is the mesial frontal electrode. So we have done a resection of the entire lesion from the anterior insula along with these electrodes which are marked in the mesial frontal network, generating where there is a spread within with a faster spread to the mesial frontal network. So the learning what we had from this is, just to talk briefly about epilepsy with myoclonic absences. The definition of this is the presence of absences accompanied by marked diffuse rhythmic myoclonia, which can affect the arms or even the head. And ictal EEG characteristically is characterized by bilateral, synchronous, symmetrical spike and wave discharges occurring at 3 Hz frequency. Actually, Bankard in 1974 has clearly mentioned by electrical stimulation, he demonstrated the precipitation of the 3 Hz spike and wave discharges by means of frontal lobe electrical stimulation, chiefly the mesio-frontal networks. And the frontal maximum of 3 Hz spike and wave discharges, which we see in absences and also the other IGEs, may be due to the involvement of the prefrontal and the frontomotor portions. So this is a clear-cut example of partial epilepsies mimicking IGEs due to a structural pathology. So there are reports of frontopolar epilepsy masquerading as juvenile myoclonic epilepsy, and also generalized 3 Hz spike and wave complexes emanating from focal epilepsy from the temporal lobe and also from the thalamus. But after doing literature search, we did not find anything coming from the insula. So we thought that our hypothesis is generalized spike and wave complexes which are generated from the excitation of the corticocortical and thalamocortical networks triggered by focal epileptiform activity. So here our hypothesis is insular lesion triggering the ictal activity, which spreads to the mesiofrontal and frontopolar networks, and from there to frontothalamic networks, resulting in the semiology of myoclonic absences. Thank you.
Excellent, excellent case, Sita. I think I wanted to say, because you are presenting must be something surgical, but then I said, no, let me keep quiet. But superb case, I think.
Thank you.
Yeah. So I think now I hand over mic to Manjri to moderate the question answer session for our all two eminent speakers, Dr. Trinka and Dr. Alexis, and also to Sita. Over to you, Manjri.
Thanks, Sangeeta. At the outset, I'd like to thank the Indian Academy of Neurology, Dr. Nirmal Surya, Dr. Gagandeep, Chaturbhuj, Sangeeta, and of course our eminent speakers who've really taught us today. Dr. Trinka, with all his work summed up beautifully in those lovely slides. Dr. Alexis, who gave us, interactive challenges. And of course, Sita's case. There are some questions posted here. The first question, of course, is for the first speaker. Dr. Eugen Trinka is still with us?
Yes, I'm here.
Okay, thank you. So there's one question here that the semiology-based prognosis is really interesting, but it is not the low CFR for convulsive status epilepticus. That's the question here. So
yeah, it's a little bit counterintuitive, because you may say that the ones with the worst motor symptoms is the most dangerous, but I think the explanation is twofold. First, when the patient is in tonic-clonic movement, it's very obvious that people do something immediately. So the time to treatment is much shorter than in non-convulsive forms. So the early treatment makes the better prognosis, and this is also seen in the randomized controlled trials. The Rampart study, for example, the earlier you treat, the better the outcome is. That's number one. Number two is in the etiologies. So the severe acute metabolic or bleeding, they don't go with generalized tonic-clonic. They very often go with comatose non-convulsive status, and these are the worst. So I think it's early recognition and early treatment which makes the better prognosis.
Thank you. So based on what you spoke, I think if you look at the prognosis, which is related to this question, there are three things which stand out. One is the etiology, and the second is the vulnerability of the age at which the status has happened. And third, of course, is, the duration of the status. For, resource poor settings, for underdeveloped areas, the time factor leads to a lot of undiagnosed and untreated status. So what would be your comments on, rescue therapy, at least for people who have a known history of epilepsy, and a routine prescription of, intranasal midazolam as a rescue therapy in these under-resourced settings, so that we could prevent prolonged status?
Yes, I think that's very important. And there are, again, from population-based studies, signs which support widespread use for rescue medications based on clinical indication. So when you have a patient with epilepsy and the caregivers or the family members give early benzodiazepines in non-intravenous routes, irrespective buccal, nasal, or even pulmonary, that improves healthcare, that prevents refractory status epilepticus, and you don't need an EEG for that. And I think this is extremely important for primary care in many countries of the world.
Thank you. The next question is for Alexis. The question is that how would you approach a patient who has the clinical phenotype of a Dravet syndrome, which is very typical, but the genetics is negative? So there's a gene panel which has been done, maybe a whole exome or a whole genome, and a specific gene sequencing, and everything is negative. There's no SCN1A or no protocoderone, mutations. So how would you approach this patient?
I suppose you mean which approach in terms of treatment?
Yeah, in terms of how would you look at the certainty of the diagnosis and, prognosticating, because, one of the very important points of having a genetics is to have a kind of diagnostic closure, and you can tell the parents, yes, this is what your child has, and then prognosticate. But then if you have a clinical scenario where Dravet is, it's a typical Dravet, but the genetics is negative, then how do you weigh in prognosticating and managing these patients? Yeah.
Well, the problem is, as you know, that even if you have the genetics, the prognosis might be different in Dravet syndrome. I mean, today, the frame of children with Dravet syndrome is not anymore what Charlotte Dravet described 30 years ago, because the discovery of the genetic defect allowed us also to enlarge the phenotype. So there are children with very severe forms of Dravet and others with a much milder expression, which probably means that we still have to discover things even within the Dravet syndrome, even with this disease. But this is not rare. I mean, the diseases do not have, even if when they are well characterized, they do not have all exactly the same prognosis. Now, to go back to your question, how I would handle this patient. First of all, in terms of treatment, let us not forget that until today, all the drugs we have are only anti-seizure medications. They are not anti-disease medications, including those that have trials in Dravet syndrome. In fact, when you read the trial, they checked if they had tonic-clonic seizures, they checked if they had myoclonic seizures, but they never checked, did you really modify the whole evolution of the disease in terms of cognition, in terms of walking comorbidities, and so on. So personally, a child that has a negative genetic screening, but has the clinical picture of Dravet syndrome, I still call it a Dravet syndrome. I'm a strongly believer in clinics, although I recognize fully what the genetics brought in our way of thinking. But I also strongly believe that those that reason the other way around are wrong, that when they find a mutation, de facto they say this is the diagnosis, it is the wrong road of medicine, because medicine changes. And what we know today will not be the same in 20 years. So what I'm doing is I'm handling it as a Dravet syndrome in the sense that I start with large spectrum drugs usually used in this syndrome. And of course, if it doesn't work, I can move to other drugs less frequently used in Dravet syndrome. In terms of prognosis, my policy is to always leave some space to the parents to discover the prognosis themselves, and for me also to discover it myself, because you know, I have seen, for example, children with a Dravet syndrome coming from a family that has a very high level of culture, and where children have 2 teachers at home and they have a lot of learning. I can assure you the prognosis is not the same than if you are left alone somewhere with no teaching, no school, nothing although they have exactly the same disease. So personally, I'm very careful with prognosis with this severe epileptic encephalopathies, and I leave some time to build it up, both for myself and for the parents.
Thank you. And now I have a question, because we know that we have been challenged with so many vaccines in the past few years. So if you have a child with Dravet syndrome, one of the common questions the parents ask is, can I vaccinate my child with any vaccine, right from your DPT pertussis as well as your, the COVID now. And so what is your advice to parents who are of children with Dravet who ask you whether any and all vaccines can be given to the child?
You know that beyond being a neurologist, I'm a pediatrician. So I believe in vaccination. I think it is extremely important to do the vaccination particularly of these children. The only thing you have to be careful is the day of the vaccination or the day after, to control if there is any fever with some paracetamol or other things, because this may trigger one seizure, but it will not trigger the disease. It is the other way around. And particularly for Dravet, you know that there is an excellent study of the Australian colleagues and Sam Berkovic some years ago, where they have proven, in fact, that the only thing that happened was that the fever provoked by the vaccination triggered the disease earlier, triggered the diagnosis earlier, because all these children that initially were suspected to have a severe epilepsy because of vaccination and a first febrile seizure, in fact, had the genetic mutation of the Dravet, and they were this was expressed some days or months earlier. So the answer is clearly yes, they need to be vaccinated without hesitation, and including COVID, of course.
Thank you. So Akansha has a question, Dr. Akansha, is that this is the reverse, that we have a patient who has Dravet mutation and a Dravet syndrome, of course, but in addition to it, has a focal cortical dysplasia or a structural lesion. So how would you approach the management of such a patient? And again, in terms of seizure outcomes, of such a patient where there is a structural lesion in addition to SCN1A mutation?
Well, this is an extremely interesting question, and it is a question that is coming more and more up, not only with Dravet, but also with other patients with a focal lesion, and at the same time a genetic abnormality. This is definitely a field that we need to study better for the next 10, 20 years. That is why I'm, again, a strong believer of the necessity to handle these patients at reference centers where the data is collected, no matter what they do at the end, but the data is collected, because we still have to learn. We will definitely make mistakes, and sometimes, and we did in the past, operate patients that had a genetic epilepsy. But the opposite is also true. The fact that you have a genetic defect doesn't de facto mean that you cannot be a candidate to a presurgical evaluation. And in this case, if the presurgical evaluation proves that the focal cortical dysplasia is the origin of the seizures, I see no reason of leaving the child with the seizures due to a focal cortical dysplasia because he has an SU1A mutation. The difference is elsewhere. The difference is on the way you present this to the patient and the family. You need to explain which are our limits of knowledge today, the fact that the child has some characteristics of a Dravet syndrome. Now, again, going back to my previous comment, are these characteristics just the genetic defect or also a clinical evolution corresponding to Dravet, plus the fact that a given type of seizures considered the dominant type of seizures comes from the focal cortical dysplasia and could benefit from surgery. So at the end is putting together the puzzle to take the decision.
Thank you. So there are several questions for you. I hope you're not exhausted.
No, it's okay.
One of the questions is, that, in India, the economical situation of patients is not always conducive to doing a genetic testing for all patients. So how would you recommend that if there's a clinical phenotype and our index of suspicion for Dravet is very high, there is a history of worsening of seizures on sodium channel blockers, which may have been used in the patient at some point of time. There's a history of hemiclonic seizures. There's a history of, febrile seizures and triggered by vaccine or not. So would you still go ahead by, without doing a genetic confirmation, saying that this could be a probable Dravet or a possible Dravet syndrome for a resource-limited setting?
You know how old am I? I mean, I said this several times to many patients before the genetic mutation. Of course, it is still a Dravet syndrome. I mean,
okay.
We didn't have the mutation until 1980 something. I don't remember 90. I don't remember in 93 or 4, I think. So, I mean, yes, if the clinical picture, and this applies to all the genetic epilepsies, is in favor of a diagnosis, the diagnosis must be put under what we have, keeping in mind that there might be some doubts or that you may need to confirm it later when a diagnostic screening will be easier or cheaper or accessible. But this, in fact, doesn't change the treatment attitude. I mean, today, honestly, eventually, with the exception of the Dravet syndrome, where there are known drugs like carbamazepine or even lamotrigine that can aggravate, I do not know of any epilepsy syndrome where the genetic diagnosis radically changes the treatment attitude. In clinical practice, yes, we learned that when you have myoclonic seizures, you don't give carbamazepine, that when you have, but all the rest is still work in progress. Even the gain of function and loss of function issues are too early to be so dogmatic. So most important is to well phenotype your patient, choose the most appropriate treatment from what we know and take it from there. And we will learn with time how important it might be or not to have the genetic identification. It is a different story at the level of research. Research is another story. We are talking about treating patients, which is not the same.
So we'll give you a break. And the next question is for Eugen. How would you term, intranasal midazolam in terms of its superiority over, say, intravenous or intramuscular preparations of benzodiazepines for, immediate in-house use? So in terms of evidence.
When we look at the evidence, which of the benzos is best, we did several meta-analysis comparisons and compared, number one, the intravenous forms against each other, intravenous lorazepam, diazepam, and clonazepam, no difference in the meta-analysis. Number two, we compared the alternative routes, intranasal, buccal, no difference, whatever you use. Intranasal diazepam was not included at the time we did that, but I expect it will be the same efficacy. So what is the conclusion of that? It's not the solution which you use, and it's not the question lorazepam or diazepam or clonazepam. It's how fast do you get the drug into the body? And that's the most important thing. So I think whatever is the best way to, whatever you have, when it's buccal midazolam, that's the choice. When you have only intranasal diazepam, that's the choice, but you have to bring it rapidly.
So that was Dr. Nirmal Surya's question. So intranasal diazepam should be used and can be used. And what is more important is to use whatever is available, whether it's intranasal midazolam or intranasal diazepam, and make sure that people with epilepsy have these at home. There's another question from Sita, and she asks, do you recommend immunotherapy in all patients where you have NOS immediately, or how aggressively would you get on board, say rituximab or plasmapheresis in a NOS patient? Like, what would be the timeline like?
Yeah, so I think there are three things to distinguish. First of all, every seizure makes a neuroimmune response. And that Anna Maria Vezzani and Eleonora Aronica, they all showed that even single seizures or epilepsy are related to the immune system. We're not talking about that now. The second is we have status epilepticus, NORS, or you can have repeated refractory status epilepticus, and you identify an immune cause. When you have the immune encephalitis with the NORS diagnosed, then we treat quite aggressively with immune drugs, including rituximab, including tocilizumab, including anakinra, but also bortezomib, which is used for NMDA encephalitis. So when you have, that's the third level, when you have cryptogenic NORS, you most often expect that there must be a cause for everything. Is a cause. Nothing comes out of the blue. We just don't know the cause. So if the cause is unknown, you have a suspicion that it's immune mediated. We do that, but we do it systematically. So we start with immunoglobulins. That's other countries start with steroids. There's virtually no comparative studies. So it's immunoglobulins, steroids, and then we do plasma exchange, because we think that this is something where all the antibodies are washed out. Then we give again immunoglobulins, and then we consider immune treatments, starting with rituximab. Why? Because we have the most experience with that. We have now switched for reasons, it's publication bias, to tocilizumab, which is also very often in use, and to anakinra. For anakinra, the problem is the enzyme induction and the turnover in the hypermetabolized intensive care patient. So you need much more than what is written in the package insert. So the dose makes the poison, which is important. And really be careful about infections. These patients are vulnerable. And when you have a severe infection, for example, herpes virus, in addition to the NORS, you are probably in trouble. So that's the dangerous thing, but we do it in exactly that protocol, as I told you before.
So I think we've exhausted the questions on the question box, and I'd request the eminent panelists, Professor Nirmal Surya, Professor Manmohan Mehendirata, Dr. Gagandeep, Dr. Chaturbhuj, Dr. Sita, Dr. Sangeeta, to chip in any questions they have. And it has been, again, I reiterate, an excellent learning session. I see no more questions coming up. I have one of my own, Dr. Trinka. I always have this feeling that maybe we should be positioning ketamine much earlier than, say, propofol. And once we've, given midazolam and the status is continuing, and we have a patient whose blood pressures are slightly dropping, I mean, why go to propofol and why go to any other agent? Why not position ketamine right after midazolam? Give a low dose midazolam along with ketamine, say 1 to 2 milligram per kg per hour, and our experience, at least my experience with our patients, has been pretty good with positioning ketamine earlier on, particularly when there are dropping blood pressures.
Yes. Thank you very much for that comment. And I fully share your feelings towards ketamine. So we use S-ketamine very early in the status, and we use it before propofol, depending on who is on charge. You see this, we are all individuals, and the doctors are habit animals. So they are used to have propofol, and then another one comes and say, no, we use midazolam and ketamine. So that's my preferred choice. Midazolam plus ketamine early in the, use it as a first anesthetic drug. For the reason which I told you, it's a very good drug and it doesn't have a negative effect on blood pressure and heart rate.
Thank you. So I think, Gagan, we are done with the series of questions.
No, Dr. Manjari, Alexi has a question. He has raised his hand.
Okay. Alexis, yeah.
I was in the process of writing it, but it's okay. No, I just wanted to ask Sita why the case presentation was excellent. What I didn't understand is why at the end you keep calling it epilepsy with myoclonic absences and not an insular epilepsy with myoclonic absence seizures, which is not exactly the same thing. You're muted.
Sita, you're muted. Sita, you're muted.
Sorry, sir. Now the semiology, see, we classify seizures based on seizure semiology. The seizure semiology is clear, and the ictal EEG together suggest it's an epilepsy with myoclonic absences. There is nothing to suggest focal onset in the ictal EEGs.
The only odd thing was there was some automatism which followed the
after the myoclonus.
After the myoclonus,
maybe I missed something, but because it was, these cases are of course very complicated. What did your stereo EEG give?
The stereo EEG showed that the seizure started from the anterior insular electrode and propagated immediately to the mesial frontal and the prefrontal electrodes, suggesting possibly it is the spread from the lesion to the frontal lobe and the frontothalamic networks which are responsible for the generation of the 3 Hz spike and wave activity.
Great, I agree. So why it is not a lesional epilepsy?
Agreed. Finally, we thought generalized, which became focal. That's why the question is it a generalized or a focal epilepsy? But insular, till now, I did a lot of literature search. I didn't find. We found
I agree. Okay, that from that point I agree. But it is a lesional structural epilepsy. It is most probably the case, and the mechanism or the proximity to the median structures could explain the clinical presentation and the discharge. But because up to now, at least, epilepsy with myoclonic absences as such is more described as a generalized epilepsy than one related to a lesion. That's why I'm trying to...
No, just to continue the conversation, there are enough papers which say that if there are focal abnormalities in MRI in patients with idiopathic generalized epilepsies, think that they are coincidental because you can have a coexistent lesions. So there is a conflicting data in the literature. So that's why I thought this is interesting.
Just one question, Dr. Trinka, where do you, at which stage do you start ketogenic diet, and how effective you think it is in the Norse?
Unfortunately, in the adults, it's very disappointing. So first of all, it's very difficult to achieve in the adult situation. They all have a gastric paresis, so you need to do it intravenously. That's very tricky, and the results are not impressive. In children, it's another story. In children, there have been a series where it's quite successful, but again, it's something which goes after, let's say, ketamine and midazolam. It goes in the super refractory stage. And maybe when you have no inflammatory signs, when you don't think that it's an inflammation, you think there is a genetic cause, you don't have it, then it's something which might be worthwhile trying. In adults, I would be very reluctant, and we had only, I would say, not catastrophes, but disappointing results.
Right. I think we are beyond our time, so it's my pleasant duty to conclude. And it's been really captivating. I think all the three talks are so captivating.
Yeah, superb.
And excellent, really fascinating presentations, and the cases were excellent. And thank you so much to the three speakers, Professor Trinka, Professor Alexis, and Dr. Sita. Apologies, Alexis, for the time confusion. And of course, the chairpersons were excellent, Dr. Sangeeta Rawat as well as Dr. Rathore. Thank you for taking chair. This has been, as I said, the brainchild of our president, Dr. Nirmal Surya, and it was his idea to have a joint meeting of the Indian Academy of Neurology and the Indian Epilepsy Society. And I think all the speakers, and of course, Manjari, you moderated and took the questions, posed the questions really well. So I think it's been a great success. I mean, the content is just amazing, fascinating, and phenomenal, right? So that's the last word is phenomenal. That's the bottom word. Thank you, Sangeeta, for that.
Yeah.
So I wanted to tell Gagan that the proceeding can be, for those who have missed out, they can go on to the IEN YouTube channel. I would suggest everybody to subscribe to the IEN YouTube channel. You can not only see all these programs, but also you could see the other programs like Freedom Series and Awareness Program and the Talks with the Legion. So you have access to all the activities which is happening, and you could choose whatever you like. Not to forget, please give your feedback so that we can continue to bring you the programs and also the rating for the speakers, because I'm sure this kind of speaker would be so useful for the neurologists, not only across the country, but also across the globe. Mansi, if you could share the upcoming program tomorrow and day after. Don't forget, tomorrow is the World Environment Day, and we have lined up this program with the World Federation of Neurology as well as the World Federation of Environment Neurology to be a joint meeting tomorrow evening at 6:30 p.m. And then it will be followed by the next week of Freedom Series on infectious disease for the API. So you all are free to choose and join us. And if you miss out, join us on the Indian Academy of Neurology news channel of YouTube.
So Nirmal, you believe in keeping us really busy. Thanks. Right.
I agree.
Thanks to the audience too. Yeah. Thank you. Thank you once again.
Thank you. Thank you.
Thank you very much. Thank you.
Thank you, everybody.
Thank you, everyone.
Bye. See you.
Thank you.